Podium, please.
Thank you very much for the kind invitation. And for the next few minutes, I will speak about Emergent TAVR. And we all know this graph. Patients with aortic stenosis have a long-standing, relatively stable clinical course, and then they deteriorate rapidly, and their prognosis is therefore dismal after that period. One question is, how many patients are those who we could expect coming to the hospital with decompensated heart failure due to AS? And in this study from 3 London hospitals with 684 patients, emergency admissions were in 141 patients. And of those, the majority had a known aortic stenosis. And as I was explained previously in a question, many patients do not have a previous diagnosis of AS. So I guess we can say that 1 in 5 hospitalizations, at least in this study, for AS are considered emergent with acute decompensation. The question is what to do with these patients. One solution, of course, is surgical AVR. We have to take into account that patients with decompensated heart failure from AS do not do as well relative to the patients who have stable symptoms. You see that surgical AVR has a worse outcome when patients have heart failure 3 or 4. And specifically on the right panel, you can see that this is true for patients who deteriorate within 1 month after the admission. So patients who, for whom we say to do some watchful waiting, and they deteriorate rapidly within a month. Even with surgical AVR, the outcome is not so great. There is a registry here from Japan, 3,800 patients, and they were divided in 3 clinical scenarios. Patients, the majority had no heart failure, you see on the left. And there are patients with stable heart failure, stable symptoms, and they're considered chronic CHF. On the right side, the patients with decompensated symptoms were considered as acute heart failure patients, and they all were divided therapeutically into conservative treatment and surgical AVR. The majority had surgical AVR. And on the right side, you can see the all-cause death in this clinical scenarios according to the conservative or surgical AVR treatment in the 3 clinical subgroups. And on the left side, the graph on the left side is not surprise. Patients who are treated conservatively, they do worse if they had acute heart failure. But the most interesting slide is on the right side, where you see that even patients who had surgical AVR, if they had no heart failure or stable heart failure, they did equally well. But if they had acute heart failure, even surgical AVR did not have the same good outcome, approximately 3 times more the all-cause death for the next 5 years. So heart failure complicating ACS has a dismal prognosis, and this cannot fully be resolved by surgical AVR. So it's not so good to wait until the patient reaches a period of decompensations. Of course, one solution is to open up temporarily the valve with a balloon. Here you see a 93-year-old male with many 4 or 5 syncopal episodes every day, with heart failure 3, class 3, also regurgitation of the mitral valve, moderate pulmonary hypertension, moderate coronary disease, who had, of course, balloon valvuloplasty that opened up temporarily the valve, and the patient, of course, was stabilized and stopped fainting. But what is the result of the valvuloplasty in these patients? Sorry. So in this from Israeli study, the patients, 343 patients, were divided with decompensated, of course, heart failure, were divided in 4 therapeutic cohorts: surgical AVR on the left, balloon valvuloplasty, transcatheter valve, and conservative treatment. And you see on the right side, of course, the best clinical cohort was the one that was assigned to TAVR, but see what's happening to the balloon valvuloplasty. Many patients within the next 12 months deteriorate clinically despite the temporary opening up, small opening up of the valve after balloon. So I think we can conclude here that, of course, TAVR is a good solution, or might be a good solution, and valvuloplasty has only a temporary relief of the symptoms. In another here German study, patients were divided in bridging with balloon valvuloplasty, and then some of them eventually were bridged to decision, meaning the valve was opened up, and then they decided what to do with the patient, and the other 20 patients were bridged to a therapy because the therapy was already predetermined by the heart team. And what you see here is a striking difference in the clinical course of patients who had balloon and then a valve, and other patients who had balloon without a valve. You see that at least in this study, within a year, most of the patients, almost all patients with only balloon without valve eventually died. So I think balloon has to be linked to an eventual decision of AVR, either after, of course, discussion with the heart team. Balloon, as it was said by Dr. Trantalis, necessitates multiple procedures, has a stenosis, mortality is high in the long run, and only temporary benefit can be achieved. In this study, which was from Hamburg, a patient with cardiogenic shock, which means even further decompensation, and that was 3.5% of the cohort, 27 patients, were judged against elective TAVR. They had emergency TAVR. You see that, of course, logistic Euroscore was much higher, more pulmonary hypertension. You see here that the clinical presentation was really bad, with altered status and cold declining scheme, shocky patients. And in these patients also had significant renal deterioration. And comparing emergency TAVR to elective TAVR, you see that this is the emergency TAVR. Many patients died. 1 year mortality is here. Many patients died in the next month after the procedure, and 25% had cardiopulmonary bypass and significant renal dysfunction or dialysis. So we can expect many complications from these patients who, even with emergency TAVR, come to the hospital with decompensation or shock. Actually, 2 out of the 3 early deaths were due to sepsis. So comorbidities do play a big role. In this multi-center study from 5 German centers, again, shocky patients, and they compared emergency TAVI with balloon, essentially. You see that TAVI, many patients died within the first month, but patients who had the balloon continue to have complications or death even after months after the procedure, whereas patients with emergency TAVR did relatively well after they survived the first month. So emergency TAVR probably is better than emergency valvuloplasty that leads to TAVR. And finally, there's a very large American registry with 72,000 patients, and eventually almost 4,000 patients who underwent TAVR for emergency presentation. And of course, these patients again had more risk factors. There were many complications, many comorbidities, worse patient compared to the elective TAVR. The device success, it's interesting, it's the same. So acute procedural success is very good. However, mortality, intraprocedural mortality, in-hospital mortality are double. And of course, double is also the renal dysfunction from this patient. No more bleedings, no more vascular complications. Within a year, you see here the mortality, double mortality in the emergency TAVR compared to the elective TAVR, and the prediction of this in patients who had emergency TAVR worse outcome could be expected in those who had oxygen-dependent lung disease, atrial fibrillation, and flutter, which is interesting. The patient who demanded the cardiopulmonary bypass and the non-femoral access. This patient with emergency TAVR had worse prognosis. And the same was held true for the one-year mortality. Again, patients with bypass, non-femoral access, atrial fibrillation, immunocompromised, and oxygen, significant lung disease fared much worse. I think we can conclude that urgent TAVR patients, which comprise approximately 10% of the total of the patients, are more complex patients with more comorbidities. The success rate acutely is the same with elective, higher 30-day and one-year mortalities. Some subgroups have much worse outcome, mainly due to comorbidities, as I showed, and may not benefit, and those are patients with significant lung disease, atrial fibrillation, renal failure, low cardiac output, mitral stenosis, and non-femoral patients. We have to be alert about these patients because they are fast-moving cases. They come with hours. They need very fast discussion with the patient, the family, the doctors. We have to acutely evaluate dementia and frailty. We expect similar procedural success, but more complication. Reimbursement is an issue here in Greece. And so in our everyday practice, I think we have to respect and consider the national Greek TAVR restriction. We don't have valves on the shelf easy to use. We have to do fast evaluation of significant comorbidities, as I said. It's logical to perform valvuloplasty as a bridge to decision or treatment. Despite temporary benefit, valvuloplasty by itself without any further escalation to AVR is probably useless in the midterm. And as I showed, if TAVR is available, probably balloon expandable valves are better because of the lower timing necessary to perform it and less contrast dye in patients with shock or decompensation. Thank you very much.
Thanks very much, Thanasi, for your excellent presentation. I think we have time to go on with the next speaker, okay? Okay, Dr. Spargias, we'll go on. What do you think? We do some questions?
I have a question.
Okay.
From the data you presented, us was very interesting data, and I think it clarified in my mind a little bit what I'm thinking every day about these patients. And according to this data, I think patients on inotropes, oxygen-dependent bypass, all these categories, I think these are the patients that they don't fare very well after TAVI, even after TAVI. So these might be the patients that you opt for BAV as a palliation, and then wait and see if they get better, then escalate to TAVI. For all the other acute patients, I think to go for states, BAV, and then TAVI, you just double the risk of the procedures because BAV has about the same risk of TAVI for mortality. Do you agree?
Yeah, I do agree. Thank you. Of course, one restriction is that we don't have the valves, in the Greek environment, we don't have the valves as they have it in Germany or in the US. So that would be logical in those countries. In Greece, it's a little bit different because we have to expect and apply for 2KC and so forth. And the other one is to realize that if we decide to do only valvuloplasty, we have to explain to everybody that this is just a palliation. So expect to come back to this the same point 3-4 months later. So they have to know that.
Okay, thanks very much, Dr. A.Manginas. Go on with the next speaker.
Okay, well, we will proceed in the next presentation with Dr. A.Chalapas, TAVI in patients with CKD or in renal replacement, please.
So I want to thank from my side